Very good afternoon. I hope everyone is doing fine. I'll go very quickly because we have already run out of topics. Run out of time. So I will start with I thought of taking a topic on thyroid, the whole of thyroid. But before that, I would like to tell you something in brief about neck swelling in general. So neck swelling or neck lumps are a common presentation in the general population and it has a number of possible causes. So the main thing is this will be important in your clinical examination. So we will discuss here the differential diagnosis, the investigation and the management of a patient who presented to you with a neck swelling. So the most common clinical presentation is that the first step in the assessment of the patient is like a detailed history and to perform a comprehensive examination. These are few of the key points that should be included in any patients who come to you with a clinical presentation of a neck lump or a neck swelling. So like any other swelling elsewhere in the body, we start with the duration of onset, any recent change in size, and if there is a change in size, whether it is a sudden change in size or it has been static over a long period of time and then suddenly increases in size, or whether it is a gradual increase in size. If there is any associated symptoms, particularly you should remember these red flag symptoms, which will be stated in the following slides. So any relevant past medical history, the smoking status, the alcohol intake, but in particular for any neck swelling, it should be any history of radiation exposure in the past. Now the key parts, if a patient comes to you with a neck swelling, it doesn't mean that you should examine only the neck when it comes to the local examination. It should extend into the oral cavity as well as the ear of the patient. So examination, like any other examination elsewhere in the body, you should introduce yourself to the patient, create a good rapport with the patient so that they gain your confidence, wash your hands, briefly explain to the patient like what the examination involves, and then approach the examination in a very systematic way. And yet you have to be prepared to be instructed to move on quickly to certain sections by any examiner. So you have to tell your patient, you have to instruct briefly what the examination involves so that they will cooperate with you along the process. Now on inspection, as usual, adequate exposure is a must of the entire neck and the patient is looking straight ahead. Then you have to inspect for any obvious lump. Remember, this is inspection. You are yet to touch or palpate the swelling. So on inspection, with the proper exposure of the neck and the patient looking straight ahead, inspect for any obvious lump just by seeing. And then if there's any scar or any skin changes, if there's any mass noted on the inspection, then if there is a mass which can be noted on inspection without even touching the patient, then you ask the patient to stick their tongue out, to take out the tongue. So any mass in the midline that arises on the tongue, on tongue protrusion is likely to be a thyroglossal cyst. Then again, ask the patient, if there is a mass noted on inspection, the next step is that you ask the patient to swallow. And sometimes you even have to offer a patient a glass of water so that they may be able to swallow, or so that for proper appreciation of the movement of the swelling on swallowing. So if there is any mass in the midline that rises up and down on swallowing, these are likely to be thyroid masses or in general a goiter. Now comes to palpation. Then the first step is that you have to stand behind the patient so that you'll be able to palpate the neck. So you have to inform the patient what you are going to do. So using the tip of the fingers, you palpate the lymph nodes of the head and the neck. So in general, you start first, you stand behind the patient, you start from the submental, which is just below your chin. Then you go, remember you have to do it with both your hands on either side of the neck of the patient. So start with the submental, just below the chin. Then you go more laterally to the submandibular on either side. Then you go more lateral and upwards to the preauricular. Then comes to the anterior cervical. then come to the supraclavicular, posterior cervical, then go backside to the posterior auricular, and then to the occipital nodes. These are the cervical lymph nodes that has to be palpated in every neck examination. And these cervical lymph nodes again can be, some can be clubbed together so that it will form the 6th level of cervical lymph nodes, level 1, 2, 3, 4, 5 and 6. So if these nodes were properly palpated in this order, from submental laterally, then coming to the going backside up to the occipital, you're not going to miss any cervical lymph nodes along the examination process. So these are the classification of the lymph nodes in the neck. Broadly, it is subclassified into 5 groups of lymph nodes, where your submental and submental, there is only a single group. Submandibular, you will get on either side. So these two forms the level 1. Then comes the upper jugular nodes, that is your, here comes your preauricular, your anterior cervical. These will fall under your level 2. Then the middle third will come your supraclavicular and your postcervical. This will be your level 3. Then the post-auricular will be your level 4, and then your posterior triangle lymph nodes. That means the lymph nodes which are situated in the posterior triangle of the neck, which includes your occipital nodes. These fall under the level 5. Then the next thing, then another thing which you should examine, it is also a gland, but it is not included under the cervical lymph nodes. It is a completely separate entity where you have to palpate it on its own separately, and should not be forgotten in any examination of the neck. It has to be mentioned. So palpation of the parotid gland is in between the, where will you locate? Because you don't see parotid gland in every normal individual. So if you want to specifically look for it, you have to go in between the sternocleidomastoid and your mandible on either side. So this is the location where you're going to palpate the parotid gland on either side. The mode of palpation of parotid gland, it has to be very gentle and palpate gently for any tenderness, any swelling or any lump over the parotid gland, and it should always be examined bilaterally on both sides. Next is your submandibular gland. This also, it should be bimanually palpate. Remember the word I use, bimanually. That means you have to use both your hands. So bimanual palpation of the submandibular gland, which involves the inferior and posterior to the body of the mandible. This is the exact location where you're going to palpate for the submandibular gland. That is the inferior and posterior to the body of the mandible. So using a glove hand, because it is a bimanual examination, that means one of your finger has to be inside the oral cavity, so you need to use gloves. So using a glove hand, press the index finger onto the floor of the patient's mouth, and you place your other index finger at the inferior body of the mandible, which is slightly away from the midline. So this is what you mean by bimanual palpation of the submandibular gland. One index finger inside the oral cavity on the and the other finger on the outside. Then ballot the submandibular gland between your fingers. That means try to move it. Like ballot means you have to try to palpate it like as if you do palpation of the kidney in their abdomen. You give a slight pressure on the floor of the mouth and you receive it on the other side finger, which is on the outside, and then again you do the reverse. You give a pressure on the outside and you receive it on the index finger, which is inside the oral cavity. So you have to check for ballotability. That means it should bounce in between the two fingers, one inside and the oral cavity and one on the other. And then you have to repeat it for the other side as well. Next is your thyroid gland. This one I will go in detail. I'll skip. Then completing the examination. After doing the examination of the cervical lymph nodes, the parotid glands, okay, and the in detail of the cervical lymph nodes, how do you complete your examination process? You should remember that if you have forgotten something important, you can go back and complete this. This is very important during your clinical examination, during your viva exam. So to finish the examination, stand back from the patient and state to the examiner that to complete your examination, you would again like to perform an ultrasonography and a fine needle aspirate of any lump identified. So during examination, if on clinical examination of the patient you found that there is a neck lump, then you can go ahead and tell your examiner that in order to enhance your diagnosis, you would like to get a ultrasonography and a fine needle aspirate of the lump detected on clinical examination. And this should be done unless the lump which you have examined clinically is pulsatile. Then an examination of the temporomandibular joint is also another important steps. Then how do you examine the oral cavity? You ask the patient to open the mouth wide and using a pen torch or an otoscope if needed, you inspect the surface of the tongue and the hard palate. You use a tongue depressor to allow movements of the oral cavity contents, and you inspect the uvula and the soft palate as well. So you examine the buccal area and the gingivo-labial or the gingivo-buccal sulcus. This also you have to inspect both lateral, superior as well as the inferior walls of this sulcus. Now ask the patient to lift the tongue. First, you inspect as it is with a mouth wide open. Then you use a tongue depressor. Then the next step is that you ask the patient to lift their tongue upwards. Here, what you can see is the floor of the mouth. And then use a tongue depressor also to move the tongue down. That is to depress it downwards. On depressing the tongues, the structures which can be seen are your uvula, your tonsillar tissue, the palatal folds, and the posterior pharyngeal walls. This is a brief, this one. On wide opening, you can see the tongue. Above is your hard palate, the soft palate. Soft palate is located in the posterior 1/3 of the upper wall of your oral cavity. Then you can see the tonsils. So this is in general what you can see on inspection. Then again, if you want to enhance further your examination, you can again like to perform this flexible Naso endoscope. This is mainly to go well beyond the oral cavity. That means upwards above the oral cavity, that is the nasopharynx, or downwards to the of the oral cavity, that is your larynx, or in general we call it a hypopharynx. Now I've been mentioning to you about the red flag symptoms for a neck lump. So these are the red flags for a neck lump. So it features the raise of suspicion of an underlying head and neck malignancy. So if any of the following signs is present, it will raise a suspicion that there is an underlying head and neck malignancy. So the number one red flag is that of a hard and a fixed lump. A lump which is hard is consistency, and when you try to do the mobility test, it is fixed and not mobile in any axis or direction. Then there will be an associated otalgia. There will be an associated dysphagia, a difficulty in swallowing. Then there will be a stridor or a hoarseness. So epistaxis or unilateral nasal congestion. This is also another red flag signs. Then another one is your unexplained. Along with the presence of a neck lump, there is an unexplained weight loss. There is a night sweat, and there is fever or rigor. See, unlike other malignancy, which usually doesn't have symptoms of fever, but those in the neck or oral cavity, it tends to be associated with a secondary infection, as a result of which patient will give you history of on and off fever with rigor. Then another symptoms that should prompt a high suspicion of an underlying malignancy is your cranial nerve palsies. If any of the cranial nerves is showing any signs of paralysis or even a weakness, it should raise a high suspicion. Then in children, red flag symptoms, it also include the presence of a supraclavicular mass, a lump which is larger than 2 centimeters, and any previous history of malignancy in the past. So now these are the differential diagnosis. So the possible causes of a neck lump can be formulated using a surgical sieve. So you really have to narrow down, okay, or shortlisted, because there are numerous diagnoses, okay, and most of them are secondary. secondary to a primary elsewhere in the body. So you should really take a thorough history, a thorough clinical examination, which should be enhanced with some investigation so that you can come shortlisted or come to a definitive diagnosis. So let's see some of the possible differential diagnosis. So the infective, it can be, the most common one is your reactive lymphadenopathy. So increase in size of the cervical lymph nodes in response to infection. Then another one is your neoplastic. Neoplastic, it can be a lymphoma. This is a hematological malignancy that commonly causes lymphadenopathy. If it is something enlargement of the lymph nodes, you will see in general the most common presentation is an enlarged lymph node. So just an enlarged lymph node, that's why clinical history and examination of the node is so important. Just a simple sign of like one node is elastic and one node is hard. There itself, it gives you a clear indication that a hard node is more in favor of a malignancy cause, and whereas that of elastic nodes, it might be due to tuberculosis or any other benign condition. Then another neoplastic differential diagnosis is your head and neck carcinoma, then any metastatic disease. This is in fact one of the commonest metastatic disease due to primary elsewhere in the body. Then a vascular differential diagnosis, it can be a carotid body tumor. This is a benign tumor that arises from the cells of the carotid body at the bifurcation of the common carotid artery. Inflammatory cause, it can be sarcoidosis. A traumatic cause can be a hematoma. And an autoimmune cause, it can be a thyroid disease such as a Graves' disease or Hashimoto's disease. So this differential diagnosis this concise one is very, very important since it involves all the possible diagnosis of a neck swelling. And the neck swelling, another differential diagnosis, it can be due to a congenital causes as well, like your cystic hygroma, which is common in children, or a thyroglossal cyst, or a branchial cyst, or a dermoid cyst, or a teratoma. So these are a few of the congenital differential diagnosis of a neck swelling. These are the pictures where you can see there is in the first picture A, there's a lateral neck lump which is caused by cervical lymphadenopathy, whereas in the other one you can see it's a completely different one. This it involves in the anterior compartment of the neck. It involves in the anterior compartment of the neck or in the central portion. So although it is both are neck swelling, but you can make out there is a huge difference. One is a cervical enlargement, cervical lymph node enlargement, and another one is definitely your thyroid gland or a goiter. Now, how will you investigate a patient who comes to you with a neck swelling? So the first line of investigation of any suspicious neck lump is your ultrasound guided. First is your ultrasonography, because ultrasound will first tell you whether it is a vascular, a solid, or a cystic swelling. If it is a vascular swelling, then you omit the requirement of a fine needle aspiration. Whereas if it is a cystic or a solid swelling, so you can go ahead along with the ultrasonography, you can go ahead with a fine needle aspiration. So going for an ultrasonography first is a must. At least it will first differentiate, because like what I mentioned in the previous slide, any pulsatile swelling which indicates a vascular swelling, you should not put a needle in it. So ultrasonography is a must to identify whether it is a solid, a cystic, or a pulsatile swelling. If it is a solid and a cystic, you go ahead in the same sitting with for a fine needle aspiration. Next, these are the different characterization that the ultrasonography will give you. It will tell you that the swelling is either a lymph node or a salivary gland or a vascular structure or a thyroid nodules. So indeed, ultrasonography findings alone can be sufficient to make a diagnosis of a certain neck lump. Now, if there is a suspicious features on imaging, that means if on ultrasonography you find that the swelling is suspicious in nature, then you can perform ultrasound guided FNAC should be performed. Now, if it is a lymphoma, then a core needle biopsy or an open excisional biopsy is preferable in this case, because a fine needle aspiration, it won't give you any, it won't be of any help if it is a lymphoma. Now, if further imaging is needed to assess a neck lump, then you can go for a CT or MRI scan. Then the CT will provide an even better picture, like visualization of the bony anatomy of the neck, whereas the MRI will provide a soft tissue detail and delineation of the abnormalities in the oral cavity as well as the oropharynx. So CT and MRI, it also aid in the management of head and neck cancer, which includes staging of the diseases, the detecting of any metastasis, as well as planning for radiotherapy. Now this is a picture showing ultrasound guided FNAC. Now a bit about cystic hygroma. What is this cystic hygroma? It has got another name as cystic lymphangioma. So it is a benign fluid-filled sac. Like the word says cystic, cyst means a fluid-filled swelling. So it is a benign fluid-filled sac which is caused by malformation of the lymphatic system. So they can be found anywhere on the body, but classically the most common site is your axilla or the posterior triangle of the neck. So it can happen anywhere where there is a lymphatic system, but the most common site is your posterior triangle of the neck and the axilla. So it is typically noticed and diagnosed before 2 years old. So it is very common it is usually diagnosed during infancy itself, the first 2 years of the child. And since it is a cystic soft fluid-filled sac, it presents as a soft, painless, fluctuant mass that trans-illuminate. This is besides other cystic swelling, which most of the time it is soft, it is fluctuant in nature. One specific characteristic of cystic hygroma is that it is trans-illumination positive. They can be associated with congenital conditions like your Turner syndrome, and it can grow to a large enough size to cause even airway obstruction or dysphagia. Usually it have the tendency to grow outwards, but when it has reached a certain limit, it will tend to grow inwards, causing external or extrinsic compression of the trachea as well as the esophagus, leading to dysphagia and breathing difficulty. However, not all cystic hygromas require treatment unless they are symptomatic. So the treatment options, it includes surgical excision or a lymphatic sclerotherapy. If it is small enough, you can go ahead for an injection sclerotherapy of the cyst. But if it is big enough, usually mainly because of cosmetic reason, we go ahead for a surgical excision. So in some cases, a cystic hygroma is diagnosed antenatally. That means while the baby is during the gestational age of the baby. And if it is likely to cause airway compromise at birth, an ex utero intrapartum treatment, in short, exit procedure, can be performed. So this is a picture showing a newborn with a cystic hygroma. In brief about carotid body tumors. So it is also known as your carotid paraganglioma. So from the name itself, if you know the synonym of cystic hygroma as cystic lymphangioma, so you will know that it is a malformation of the lymphatic system. And so the other synonym for carotid body tumor is your carotid paraganglioma. So from the name itself, you will know that it is a benign neuroendocrine tumors that arises from the paraganglion cells of the carotid body. So the carotid body is made up of a cluster of neuroendocrine cells whereby sporadic or sometimes hereditary mutations lead to the formation of paragangliomas. These carotid body tumors, remember, they are vascular in nature, so they will present as a pulsatile, painless neck lump. This is the commonest presentation, and then it often with a bruit present on auscultation. So when you auscultate over the swelling, you will get a bruit. So carotid paragangliomas are slow growing but can become large enough to compress the surrounding cranial nerves, leading to cranial nerve palsies. They can be managed conservatively with active monitoring via serial imaging, or sometimes it requires surgical excision in a specialized unit with both ENT and vascular input. So radiotherapy may be an option for tumors that are unresectable to limit the growth of the tumor. Classically, these carotid body tumors, it can be moved from side to side but not up and down. So this is one of the peculiar clinical features of a carotid body tumor. They can be moved side to side. When you do a mobility test, side to side mobility is positive but not up down. This is due to their location in the carotid sheath. There is restricted movement due to the carotid sheath up and down. Another swelling is your thyroglossal cyst. This is also a congenital fluid-filled sac, which is commonly present in younger patients, usually before the age of 20 years, and it has an equal incidence between male and female. So thyroglossal cyst, it presents as a palpable, painless midline mass. Remember, it is midline, not on either side of the midline, and it moves up with protrusion of the tongue. And when infected, they can increase in size and become painful. So the standard treatment is your surgical intervention, which is known as your cyst trunk operation. It is being widely used. Here, the central body of the hyoid bone is removed to allow complete removal of the entire thyroglossal tract, and there is a high chance of recurrence if the medial portion of the hyoid bone is not removed. In rare cases like that, in around approximately 1% of the cases, patients may develop a thyroglossal duct cyst, carcinoma, that often arises from ectopic thyroid tissue in the cyst. So the most common histology, if such a scenario happens, is your papillary form. So this is a midline swelling. If you ask the patient to protrude the tongue, it will move up and down, and it is usually always at the level at or above the hyoid bone, not below the hyoid bone. If you see a midline swelling below the hyoid bone, you can think of a thyroid gland, and above and at the level of hyoid bone, it can be a thyroglossal cyst or a thyroglossal duct cyst or a thyroglossal fistula. Now, a bit about the embryology of thyroglossal cyst, why it happens only in the midline and why it happens at or above the level of the hyoid bone. So during the embryonic development, the thyroid gland originates from the base of the tongue. At the embryonic stage, it is known as the base of the tongue is known as your foramen cecum. Then from there, from the base of the tongue, it migrates down to its final position in the neck and connecting back to the tongue via the thyroglossal duct. So failure of these, so at birth, usually this thyroglossal duct, that is the connecting band from the base of the tongue or the foramen cecum to its final position, if it failed to regress at birth, it can give rise to your thyroglossal duct. So what happened is, in normal development, this duct will obliterate. However, the thyroglossal cysts occur when portion of the duct remains patent, creating cavities that may fill with fluids and being prone to infection. Now, what is a branchial cyst? A branchial cyst is also another form of neck swelling, which are congenital masses which arise in the lateral aspect of the neck. Unlike your thyroglossal, which is always in the midline, this one is the lateral neck swelling, which is typically anterior to the sternocleidomastoid muscle. What happened is that during the 4th week of development, the branchial clefts from the ridges known as the branchial arches involve in the formation of a number of structures in the head and neck. So what happened is it undergoes incomplete obliteration of these clefts, which result in the formation of the branchial cyst. They present as a palpable mass anterior to the sternocleidomastoid, typically unilateral. It can happen either on the right or on the left side, either side of the center of the neck. And when infected, they can increase in size and become painful. So a larger branchial cyst can result in dysphagia, dysphonia, and difficulty in breathing. Surgical excision is the definitive treatment if such a cyst appear. Sclerotherapy can also be offered as an alternative to surgery in certain cases, which involves injection of a sclerosing agent under ultrasonography guidance. Care needs to be taken when managing these patients, as a common differential diagnosis is a cystic metastasis from a squamous cell carcinoma of the head and neck region. As such, an ultrasonography guided FNA is an important investigation prior to arranging for excision of the mass. So one thing you should learn, the bottom line about any neck swelling is that always do an ultrasonography first. Distinguish solid, cystic or pulsatile mass. Rule out pulsatile mass. If it is solid or cystic, always go for a FNA. Don't be so overconfident, okay, this is a cystic swelling, I think it's a sebaceous cyst in the neck, and you straight away ask the patient for a excision. Then on biopsy, it will come out something else like a metastatic lymph node or something else. So always go for a ultrasonography, and it is the most non-invasive investigation which is not going to cause any harm to the patient. So a patient with a large right branchial cyst here prior to excision. So what are the key points is that neck lumps are a common presentation in the general population, and it has a wide range of potential differential diagnosis. Investigation of a neck lump following history and examination, if suspicious, will require ultrasonography plus or minus fine needle aspiration. If lymphoma is suspected, a core biopsy or an open excisional lymph node biopsy will be preferred over a fine needle aspiration to obtain a histological diagnosis. CT or MRI scanning may be carried out for further assessment once an initial diagnosis is made. So that is in brief about any neck swelling. So I'll move in detail now to thyroid gland. So the word thyroid is derived from a Greek word thyroides, which means a shield shape, because a thyroid gland resembles the shape of a shield. Remember, it falls under the category of an endocrine gland, like that of your pancreas. Its main function is that regulation of the basal metabolic rate of the body, and it also stimulates the somatic and mental growth, and it plays an important role in calcium metabolism. A bit about the surgical anatomy. It comprises of two lobes, one on either side, which is joined in the middle by an isthmus. Sometimes, in 80% of the cases, there is an extra lobe which is known as your pyramidal lobe, which usually projects upward from the isthmus, or it can arise from either side of the lobes, either from the left lobe or the right lobe, or it can arise from the isthmus. This is seen in 80% of the cases. Now, a fibromuscular band, which is known as your levator glanduli thyroidi, it descends from the body of the hyoid bone to the isthmus or to the pyramidal lobe. So in this condition, it is known as your levator glanduli thyroidi. There is a reason why it is named as your levator glanduli thyroidi. This you will come to know in the coming slides. Now this is a brief picture. You see the right lobe, the left lobe. It is situated just anterior to your trachea. It comprises of right lobe and left lobe, which is joined in the middle by the isthmus. Now in 80% of the cases, you will see that pyramidal lobe, which usually arises from the isthmus and extending upwards. Or in certain cases, you get the levator glanduli thyroidi, which is an attachment from the hyoid bone to that of the pyramid lobe, more commonly, and sometimes to either the right or the left lobe. Now, where is the exact location of the thyroid gland? It lies against your C5, C6, C7 and T1 vertebrae. It claps the upper part of the trachea. So it engulfs the upper portion of the trachea. It is situated anterior to the trachea. The trachea is situated anterior to the vertebrae, and the thyroid is anterior to the trachea. So each lobe, if you see in the picture, each lobe, it extends from the middle of the thyroid cartilage. You see another shield-like structures upward, that is your thyroid cartilage. So it extends from the middle of the thyroid cartilage to the fourth or fifth tracheal rings. And whereas that of the isthmus, it extends from the second to the third tracheal rings. Each lobe measures approximately 5 centimeter into 2.5 into 2.5. That is length into breadth into width. The isthmus measures around 1.2 into 1.2 centimeter. And in overall, the thyroid gland generally measures around 25 grams. It is slightly larger in females than male, and it increases in size. These are the conditions where you can see a normal enlargement of the thyroid gland, that is during pregnancy or sometime during menstruation. Now, what are the capsule which engulfs or which encloses the thyroid gland? We have broadly divided into the true capsule and the false capsule. The true capsule is the peripheral condensation of the connective tissue of the gland. That means it is a part of the gland itself because it is formed by peripheral condensation of the connective tissue of the thyroid gland itself. And another capsule, we have the false, also known as the surgical capsule. There is a reason why we also call the false capsule of the thyroid as a surgical, because it plays an important role during a thyroidectomy, surgery on the thyroid gland. So it is derived from the pretracheal layer of the deep cervical fascia. So now, what are the applied anatomy? Now you remember that there is a dense capillary plexus is situated deep to the true capsule. So to avoid hemorrhage during surgery, the thyroid is removed along with the true capsule. The reason is because there is a dense capillary plexus which is just deep to the true capsule. But how will you differentiate it from that of the prostate? In case of a prostate gland, these venous plexus, they lie in between the two capsules, and therefore during prostatectomy both the capsules are left behind and only the prostate gland is being removed, whereas that of a thyroid gland you have to remove along with the true capsule because you cannot separate it from this capillary plexus because it is situated in very close proximity just deep to the true capsule. Now what are the components of the deep cervical fascia? It has got 4 components: the investing layer, the prevertebral layer, the pretracheal layer, and the carotid sheath. So remember, the false or the surgical capsule is derived from the pretracheal layer. A bit about this suspensory ligament of Berry. What is this suspensory ligament of Berry? So the pretracheal layer, which engulfs the thyroid gland, it is thin along remember it engulfs the entire thyroid gland, and what happens is that along the posterior border of either lobes, both the right and left lobes, it is thin. Along the entire gland it is a thin layer, but on the posterior border of the lobes it becomes thick on the inner surface, where it forms a suspensory ligament of Berry which connects the gland to the cricoid cartilage. So it is nothing. Basically, a suspensory ligament of Berry is a portion of the pretracheal layer itself which is slightly thickened on the posterior side as compared to that of the rest of it, and it connects the gland to the cricoid cartilage. And this is one of the reasons also like why the thyroid gland moves up and down on swallowing. Now these are the reasons. On clinical examination, whenever you see a midline swelling, the first thing you ask is to protrude the tongue. If it moves up, then it is a thyroglossal duct or cyst. And then again you ask the patient to swallow. Sometimes you might have to offer a glass of water. If it moves up and down, then it is a thyroid gland. Now, why does a thyroid gland moves up and down with deglutition or with swallowing? The reason is that because it is attached to the hyoid bone, and the hyoid bone moves on deglutition, so it pulls along with it the thyroid gland. The second reason is that because of the pretracheal fascia, which gets pulled up on deglutition. Another one is your ligament of Berry, which I have told you in the previous slide. So these are the reason why a thyroid gland moves up and down with deglutition. Now, what are the structures which are enclosed in the pretracheal fascia and it moves up and down? Now, all structures which moves up and down again are not there are different condition which can cause upward and downward movements on swallowing or deglutition, like your thyroglossosis, your subhyoid bursitis, pretracheal lymph nodes, prelaryngeal lymph nodes. Now, what is the relationship of the thyroid gland with the strap muscles of the neck? This is also again important when you perform a surgery on the thyroid gland. So the relationship with the strap muscles is laterally you have the sternothyroid muscles, anteriorly you have the omohyoid and the sternohyoid muscles. Usually in order to expose the thyroid gland during surgery, there are conditions where we even have to cut these particular muscles if they are tense enough and they cannot be retracted with the help of a retractor. Then inferior relation with the strap muscle is your sternocleidomastoid muscle. Remember, the motor nerve supply from the ansa cervicalis, it enters these muscles inferiorly. So it comes from below upwards. Now the vascular anatomy of the thyroid gland. Remember, the thyroid gland is a highly vascular endocrine gland. The main arteries which supplies the thyroid gland is your superior thyroid artery, inferior thyroid arteries, and your thyroidema artery. So the tracheal and esophageal branches serve blood supply to retain the thyroid gland after thyroidectomy. Because during the thyroidectomy procedure, you first have to ligate and cut these particular blood vessels. So the remaining thyroid gland is usually gets its blood supply from the tracheal and the esophageal branches. So this is the brief diagrammatic picture of the vascular anatomy of the thyroid gland. What about the venous drainage? There are mainly three veins which drains into the thyroid gland. This is your superior thyroid veins which drains into the internal jugular vein or the common facial vein. Then we have the middle thyroid vein which also drains to the internal jugular vein. Then we have the inferior thyroid veins which drains into the left brachiocephalic vein. Then sometimes a fourth vein is also present, which is known as your Cocker's vein, which emerge between the middle and the inferior vein, and this also drains into the internal jugular vein. What about the nerve supply of the thyroid gland? It is principally the nerve innervation of thyroid gland is from the autonomic nervous system. But there are also parasympathetic fibers which are usually derived from the vagus nerve, as well as sympathetic fibers from the superior, middle and inferior ganglia of the sympathetic trunk. These nerve innervation, they enter the glands along with the blood vessels. So they usually follow the same course as that of your arteries and veins. What about the lymphatic supply of the thyroid gland? It is primarily to the internal jugular nodes. So most of the lymphatics which arises from the thyroid gland, they primarily drain finally into the internal jugular nodes. So we have also the superior pole and medial isthmus which drains to the superior groups of lymph nodes. The lower pole of the thyroid, it drains to the inferior group, and then it finally everything empties into the pretracheal and the paratracheal lymph nodes. So the main lymph nodes that should be examined for any thyroid gland is your nodes along the internal jugular vessels and the nodes along the pretracheal and the paratracheal region. So these same nodes can be again divided into primary and secondary. The tracheoesophageal nodes, the prelaryngeal nodes, also known as your Delphian nodes, and the mediastinal nodes. This comprise the primary lymphatic drainage of the thyroid gland. And then the secondary drainage from the deep cervical nodes, supraclavicular nodes, and the occipital nodes. These are the lymphatic arrangements. So the most important applied anatomy, this is from a surgical perspective. Whenever you do a surgery on a thyroid gland, the vessels, you can sacrifice it. Superior thyroid, inferior thyroid artery or veins can all go away. But you should always remember to spare the recurrent laryngeal nerve. This recurrent laryngeal nerve, it supplies the intrinsic muscle of the larynx, except the cricothyroid, which is supplied by the external laryngeal nerve. So any accidental damage to this recurrent laryngeal nerve during surgery, it can cause ipsilateral vocal cord paralysis, and it can even cause difficulty in phonation. The person won't be able to produce sound on talking. Now, this right recurrent laryngeal nerve, it arises from the vagus, and from there it crosses the first part of the subclavian. A loop under it runs oblique to enter the larynx at the level of the cricoid. Whereas the left recurrent laryngeal nerve, after origin from the vagus, it crosses the aortic arch loops posteriorly around the ligamentum arteriosus ascens, medially in the tracheoesophageal groove. So superior laryngeal nerve has an internal branch, that is a sensory, and an external branch which is motor, and it helps in vocal cord tension and the pitch of the voice. A superior laryngeal nerve runs in close proximity to the superior pole vessels. To avoid injury to the superior pole vessels, it should be individually ligated and divided. So this is the important steps during surgery, that superior vessels should be individually ligated and divided. You should not altogether ligated. Then it should also be low on the thyroid gland. That means you should ligate it as close to the thyroid gland as possible, and dissected laterally to the cricothyroid muscles.